Today we will see about anterior circulation stroke. The incidence of anterior circulation stroke ranges from 105 to 152 per lakh population in India. Stroke is the fourth leading cause of death, and 2 million neurons die every minute after a stroke. Time is brain, and timely recognition and treatment is very vital. So it's a true medical emergency where you can make a big difference in the quality of life. So we'll discuss under four headings, namely anatomy of the brain, blood supply of the brain, pathophysiology of the anti-circulation stroke, anterior circulation stroke syndromes, and the management of anterior circulation syndromes. Looking at the anatomy, we are all aware that we've got two cerebral hemispheres, four lobe, frontal, temporal, parietal, occipital, and cerebellum. And this is the sagittal section, which has a limbic system, anterior cingulate gyrus, posterior cingulate gyrus, hippocampus, amygdala. Also, the corpus callosum connecting between the two hemispheres, thalamus, hypothalamus, as well as the pituitary gland. And looking at the coronal section of the brain, at the frontal section, lateral and third ventricle, cardiac nucleus, putamen, globus pallidus, septum pellucidum, as well as corpus callosum at this coronal section. And here you see the pyramidal tract coming down, as well as the lenticular tract branch of the middle cerebral artery goes there. The red nucleus, substantia nigra, hippocampus, and fornix, and the sensory tract you see in this cut section of the parietal lobe. And the posterior, the occipital lobe, which has got optic radiation and which is supplied by the posterior cerebral artery. And this is the functional anatomy, area 1, 2, 3 of Brodmann, which receives the touch, pain, temperature receptors from the body and ascend up in the spinal cord and reaches the sensory cortex. This is how the signals are carried through the spinal cord, crosses to the opposite section, and then it ascends up and reaches the thalamus and then the sensory cortex. Area number 4 is the main motor cortex, which gives rise to pyramidal tract, and which arises from the bed cells of the gray matter, comes as corona radiata and internal capsule, and proceeds to the corticobulbar and corticospinal tract, which is involved in the muscle contraction and movement. So the main function is the movement. Now the area 44 is the Broca's area, which is the speech area, expression of speech, produced by complex muscle movements, which is controlled by the area number 44 of the throat and the tongue. Area number 41 and 42 is a language or reception, and process the various sounds and make sense of the language as well as the music. And it's also called Vernix area, which receives the speech signals. And area number 17, 18, and 19 is the visual cortex, which receives optical signals from the optic nerve, optic chiasma, lateral geniculate body, and pretectal region, as well as the optic radiation. And finally, the visual signals are processed as occipital cortex. Now, the blood supply of the brain. Blood supply is supplied by the two anterior internal carotid artery and two vertebral arteries posteriorly, and this is the lateral surface is supplied by middle cerebral artery, polar branch, orbital branch, anterior and posterior branches. It's the middle cerebral artery which has got upper and lower division. Also finer branches you can see. The anterior cerebral artery, there's a callosal branch and pericallosal branch, and also finer branches. And the top view, you see the posterior aspect is supplied by the posterior cerebral artery and anterior cerebral artery. Now the inferior aspect of the brain, you see the circular villus formed by anterior cerebral artery, middle cerebral, the internal carotid artery, and the vertebral artery. It forms the circular villus, and from there the anterior cerebral artery, anti-communicating artery, posterior cerebral, posterior communicatory artery forms the circular villus, and the branches, that is the main branch, the lenticular striate branches comes from the middle cerebral artery. Also, the superior cerebellar artery, anterior inferior cerebellar, and posterior inferior cerebral artery
Or branches of basilar artery.
and the posterior cerebral artery supplies the occipital cortex. The pathophysiology. So, what happens to the blood vessels? So, atherosclerotic plaque is formed due to various reasons, and that is the main precipitating factor. And then it is The superadded injury is caused by the block and the clot. And the clot sometimes blocks the arterial supply, which is the ischemic infarct it causes. Sometimes they gets ruptured and the clot gets into the bloodstream and travels to the distal part of the arterial system and ends up in the cerebral circulation and causes the blocks. That's called the embolic stroke. So the first one is thrombotic or thromboembolic. Second is the embolic stroke. And it goes up into the circulation, and the common block area is the middle cerebral artery branch of ventricular striate artery. Also, it can cause a block in various other areas. If you see the coronal section, you can see the MCA and you see the corresponding infarct of the CT brain, and similarly, it can cause the branch orbitofrontal branch may be occluded, or it can cause occlusion of the middle cerebral artery of the inferior branch, that is polar branch, so which is a lateral aspect of the brain, and see the infarct there. And sometimes the anterior cerebral, there is a pericallosal branch may be involved, and you see the middle aspect of the brain is involved. Also, sometimes the pericallosal or callosomarginal branch, which causes the superior aspect of the frontal and parietal area, and you see the infarct in the CT scan. And the posterior circulation, there is the posterior cerebral artery supplies the occipital cortex, and you see the infarct is reflected in the CT scan. So these are all the pathophysiology with relevant to the ischemia. Now the hemorrhage, which is another etiology, and you see because of hypertension and various other reasons, there is a hemorrhage because of rupture of the blood vessel. You see the subarachnoid hemorrhage at the base of the brain. Sometimes you can see the intracerebral hemorrhage occurring in the parietal or frontal area, what you can see. So this hemorrhage is another etiology of the stroke. It's called hemorrhagic stroke. Coming to the anterior circulation stroke, ischemic strokes, there are four main branches are involved: anterior choroidal artery, anterior cerebral artery, middle cerebral artery, and internal carotid artery. Of which the middle cerebral artery is the commonest one, of which is the commonly affected at causing stroke up to 70%. And the anterior choroidal artery is not very common because it arises from the internal carotid artery, and it causes anterior choroidal artery syndrome. You see the block of the anterior cerebral artery, it causes orbital or frontal polar branch may be affected, or medial striate artery, that's a recurrent artery of Hübner, a different clinical profile, and also the callosomarginal may be affected. And if you see the middle cerebral artery, the stem, upper division, lower division may be affected. Sometimes you can find lacunar infarcts. And the internal carotid artery usually presents as transient ischemic attacks, and caused by the transient loss of vision. And you see the anterior choroidal artery presents as contralateral hemiplegia, contralateral hemisensory loss, hemianopia. This is the common triad. Also, you may find intention tremor of the contralateral arm. This is called atoxic hemiparesis. That is the important stroke with the ataxia. There is anterior choroidal artery involvement, and you see the contralateral upper quadrant anopia, or sometimes upper quadrant hemianopia. And coming to the anterior cerebral artery strokes, and if the orbital branch is involved, the patient may be apathetic, memory loss. Also, they may have dysarthria, hoarse voice, dysphagia. And if the callosomarginal branch is involved, you might find motor weakness, abulia, contralateral lower limb cortical sensory loss, and urinary incontinence. The pericallosal branch involvement causes ideomotor apraxia, tactile anosmia. So those are all very important clues. Coming to the middle cerebral artery strokes, the contralateral hemiplegia, contralateral hemisensory loss, hemianopia, global aphasia, especially the involvement is on the left side, also contralateral sensory hemineglect. These are all the classical symptoms you see. This is the most common type of stroke you see. The gaze towards the side of the infarct, the patient looks at the side of the infarct, and this is the common. So if you look at the branches of the middle cerebral artery, if you see the upper segment, you see contralateral hemiplegia, contralateral hemisensory loss of the face and arm only, hemianopia, dysarthria, and Broca's aphasia and contralateral hemineglect on the right side. And if you see the middle cerebral artery involvement of the lower division, you see the contralateral hemianopia, also the confused vegetative state, Wernicke's aphasia, alexia. So this is about the lower division. Now coming to the internal carotid artery, and you see the transient ischemic attacks, the heaviness of or weakness, numbness, and tingling of one arm or one leg, slurred speech, not hemiplegia, transient monocular blindness. So we know we have discussed about the various stroke syndromes involving the anterior circulation stroke. Now coming to the management of stroke syndromes. So far we have covered the anatomy, blood supply, pathophysiology, and various clinical stroke syndromes of anterior territory. Now we'll come to the action part. That is, how do you manage that? That's the management of acute anterior circulation strokes. The pre-hospital care. The care of the stroke patient starts at home. You have to make things aware that the patient should be able to recognize that they have got stroke. The internationally followed abbreviation is B fast. That's the B stands for balance loss, that is the incoordination or ataxia. Eyes blurred, unclear vision, double vision or gaze. So there's something to do with the eye movement or vision. Or facial sagging, facial weakness on one side, or facial asymmetry. If the patient finds arm or leg are together, weakness on one side, and speech difficulty or slurring of speech. So this forms the B fast. And if the patient is able to see one of these symptoms of balance, eye, facial weakness, arm weakness, they should alert the physician. That's it. So you must make aware of the public about all these things. And again, the time is brain. The clock starts ticking. The patient needs acute intervention, immediate help. And so you have the transportation. Before that, some of the advanced countries may have the ambulance equipped with the imaging and communication system, where the attending physician from the hospital may communicate and do the physical examination and make sure that the patient may have a stroke, and arrange for a CT scan, which is available within the ambulance. So the patient takes the CT scan to the hemorrhage, and the image goes in the packs to the hospital, where they interpret, and the patient is shifted quickly. Sometimes in the hilly areas you can use an air ambulance to save time, and when the ambulance reaches the hospital, either through surface transportation or air transportation, the time is very critical. So at the hospital, you start clicking the door to ED time. You should make sure that if it happens less than 10 times after the patient entry into the hospital door, and you should reach the emergency or casualty within less than 10 minutes. So at the emergency department, you have a protocol, you triage, and if the patient has got an emergency or acute stroke symptoms, the stroke team is alerted, our stroke code is activated, and you pass an IV catheter, take a blood sample, do the blood glucose, do the clotting profile, and do a blood pressure measurement. Also, the ED physician should be able to stroke scoring if possible, and alert the neurology team is involved in the acute stroke team. And you also inform the imaging center about the urgent CT, and you call the consultant and arrange for the CT as early as possible, and try to get the report back and call the neurology consultant, and who is going to reassess the history and physical examination and see, make sure if it's a stroke, and he assesses the stroke time, that is the onset of time. So the door to CT time, door to interpretation of CT time, door to neuro consult, and door to lab, those are all 25 minutes, 15 minutes, and 30 minutes respectively should be followed. And you keep watching the clock and keep doing the physical, and keep calling everybody, because it should be very urgent and quick. And the neuro consultant or the attending physician of the stroke patient does the scoring using the National Institute of Health Stroke Scale, NIHSS, involving the consciousness, orientation, response to commands, gaze, if there's any problem with the visual fields, any facial weakness, or if the patient's got a motor dysfunction of arm, right or left, leg, right or left, or limb ataxia, sensory dysfunction, language dysfunction, disarticulation, or inattention or extinction. So these are you come out with a stroke and categorize the stroke into mild, moderate, and severe. And now coming to the management part, you shift the patient as early as possible into acute stroke unit if there is one. Otherwise, the patient has to go into the acute stroke unit. If you see that the patient got a tense hemiplegia with the loss of consciousness, and if it's a severe one, it has to go into a neuro ICU, else otherwise it goes into the acute stroke unit. And the protocol is emergency CT non-contrast as quick as possible. So again, the time, door to imaging time, due to reporting time of the CT and rule out the hemorrhage. And if you confirm that the patient has got a stroke, ischemic stroke, and if they come between 3 to 4.5 hours, he is eligible for thrombolysis, and you arrange for to thrombolize using the alteplase. So if you see the blue ones are the alteplase, if you give him time, it lies there, and if it's recanalized, and you see the reperfusion, and probably the ischemic penumbra is safe. And you can also use the transcranial ultrasound sometimes to see if there is a large vessel large sitting there. There is one of them, so it's not regularly used though. So having done all these things, so then finally, if you suspect that there is a large vessel block involving the internal carotid artery or the proximal portion of the middle cerebral artery, you may have to think about mechanical thrombectomy or endovascular therapy. To ensure benefit, reperfusion of TICA grade 2B by 3 should be achieved as early as possible within 6 hours of stroke onset. That is the ideal goal we set for that. So so even if it is less than 6 hours, that's good. So that's the protocol every hospital follows, and see who is eligible for alteplase. So you have an inclusion criteria, diagnosis of ischemic stroke causing measurable neurological deficit, and treatment within 4.5 hours or less, and you exclude if the patient has got a current intracranial hemorrhage by CT or supracranial hemorrhage, acute internal bleeding diathesis, or recent intracranial or intraspinal surgery, or severe recent head trauma, a current severe uncontrolled hypertension. Those are all not eligible people to receive the alteplase. And additional criteria: if the patient is very aged, more than 80 years, very severe stroke of NIHSS stroke scale is more than 25, history of diabetes and previous stroke, and patient may be taking anticoagulant for other reasons, regardless of INR. Even if the INR is stable, still you don't take any risk to infuse alteplase. And it has got its own risk as well. So you have to make sure that if the large vessel occlusion is suspected, and you have to make a decision about doing mechanical thrombectomy or endovascular therapy for the patient, especially the large vessel occlusion. After the patient is admitted at alteplase and the cause is deemed to be occlusion of the large vessel, you have to use a stent retriever. And the criteria for endovascular therapy is within 6 hours of stroke onset, pre-stroke modified Rankin score is 0 to 1, and acute ischemic stroke receiving alteplase within 4.5 hours of onset according to guidelines from professional medical societies, and causative occlusion of the internal carotid or middle cerebral proximal branch of middle cerebral artery, age 18 to or older. NHS stroke scale is more than or equal to 6. Alberta stroke program, early computed tomography scale, there's aspects of more than or equal to 6. And treatment can be initiated by using the groin puncture within the 6 hours of symptom onset. So the alteplase is not the end of the story. You have to start treating the patient with the mechanical thrombectomy, and which is done by the neuroradiologist or stroke neurologist or neurosurgeon, and depends on the resource available. And it has got a lot of benefits. The use of alteplase, between use or not use, overall outcomes better, 43% versus 32%. Patient is able to manage the daily living 53% versus 32%. No or minimal deficit 1 year after stroke is 39% versus 26% at 3 months time, and none to minimal disability at 90 days. That after 3 months, you see the benefit is still high. That's 52.4% versus 45.2%. So alteplase therapy is the commonplace, and you should not miss the patient if the patient is eligible for that. It's got some problem, and what are the risks of alteplase? If you enhance the bleeding, and sometimes it may give rise to the hemorrhage, and the patient may have headache, or the neurological symptoms may worsen, and you have to think about that, do a CT scan, and also assess for the large vessel occlusion by if the patient has got an arm drift, and see the gaze, and see the patient is able to obey the commands, and also ask the patient to touch and say. There is an assessment and all that time. So facility should be available, and you should be able to do it on time within 6 hours. So this is how the mechanical thrombectomy is done. You see the trocar is passed in this animation. it enters into the femoral artery, and after it is punctured, the guide wire is introduced into the trocar, and it goes all the way up through the femoral artery, and it reaches the aorta, and it goes further into the heart to the left side, and then you twist the wire, and it reaches the internal carotid artery, and it goes, and under the C-arm you see it like what you do for the coronary angiogram. It's just similar thing, and the arterial route is different, and it reaches the clot of the large vessel, and it goes through that and still further. So it is placed the guide wire, and then a sheath is introduced over the guide wire, and from the groin it goes all the way up, and the sheath comes into the location where the guide wire is there, and then the guide wire is pulled up, and the clot retriever is introduced, and then the sheath is removed, and the clot retriever just catch hold of the clot, and then you will be able to gently remove it so that the blood flow is replenished, and there is a good prospect for the surviving ischemic penumbra. So that's about that. And again, you don't forget that there is a risk of hemorrhage when you cross all the way up. Just sometimes there is a puncture of the artery where you are manipulating and may end up in hemorrhage. And acute hemorrhagic stroke is another variety than the ischemic variety, and you have to assess them carefully according to Glasgow Coma Scale, age, location, intracranial hemorrhage volume, intraventricular bleed, and ICH score. So accordingly, the mortality is graduated, and you have to put the patient into neuro IC, and you don't give alteplase. And you see the markers of bad prognosis of stroke both. So subarachnoid hemorrhage is a bad prognosis, intracerebral hemorrhage is bad prognosis, as well as intraventricular bleed and hydrocephalus ischemic, large ischemic stroke, and the patient who needs decompressive craniectomy. And you consider that in the people who is bleeding inside needs the blood pressure to be controlled between 120 and 140. The head should be little elevated. At 30 degree, consult a neurosurgeon quickly, and you don't give routine prophylactic anti-seizures unless it is indicated and advised by the neurologist. And the management of stroke doesn't stop here, and the acute part is over. You try to do your best, and now the patient is on second day or third day, and start the patient on physiotherapy. That is the rehabilitation. So try to make the residual with the weakness, try to make the patient more ambulant, try to make him fit for all daily activities using active physiotherapy with the support of the physiotherapy team, and let them assess every day and try to mobilize them. Also, the second part is the occupational therapy. So you give some simple instruments to catch hold of that. So with the residual weakness, they should be able to make a cup of coffee, help themselves in the toilet, and as much as possible. That is done by occupational therapist. Also, finally, the social aspect. So social service people will come in. So in our case, in India, people, the relatives who will be supporting the patient at home should be discussed whether the patient is living in the upstairs or downstairs, should be able to climb stairs, and what is the functional capacity and all that, and judge the patient going where he's going back, and will be able to fit the environment is fit for them to live. So that's a greater responsibility before discharge, and then also see whether the patient should come back as a stroke. So you have the responsibility to prevent the secondary stroke. So now you take into consideration of the various aspects. If the patient has got a stroke or TIA, in the high risk for recurrent stroke, or blood pressure more than 138, control it. The DM, diabetes, treat it aggressively, and LDL cholesterol has to be physically make them active and put them on diet, and ask them to quit smoking. So also the patient is drinking alcohol, ask them to quit, and then the patient has got AF, treat them with antiplatelet or anti-try. The patient has got a sleep apnea, put them on sleep studies, and try to ask them to reduce weight and use some CPAP to antiplatelet therapy. The AF patient may need anticoagulant for months, and then you may put them on combined antiplatelet therapy for some time, and then you may, after 6 months or so, you can put the patient on single antiplatelet agent and monitor for the metabolic parameters. To summarize, stroke is a medical emergency. Pre-hospital and in-hospital delay has to be reduced by rapid transfer to acute stroke units. Timely intervention will save brain and thereby reduces morbidity and mortality. And public awareness of Be Fast has to be spread. Stroke-ready hospitals will have imaging, etc., and should be earmarked around, or any hospitals receiving stroke patients should have local protocols to follow protocol, so that the patient will be taken care of and managed very effectively on time. Thank you.